Hello everyone. I hope I'm audible and visible. Okay. Uh, Hello everyone. I'm Mishwa Shah, the Animal Welfare Head of IVSA India. I'm currently in my third year of Mumbai Veterinary College, and I'm extremely delighted to welcome Dr. Sumanth Bedre sir, who is who will be sharing his knowledge and expertise on the topic of cardiopulmonary resuscitation. So, Dr. Suman sir, he finished his graduation in year 2016 and finished his masters in the year 2018. He has been working with WVS India since the year 2018. He is currently the clinical director at WVS UT. His interest lies in small animal surgery, anesthesia, and emergency critical care. We also have our president, Ajay Rathi, over here. Ajay, can you please speak a few words?
Yes, thank you so much, Vishwa. First of all, I would like to express my deepest gratitude towards Dr. Suman sir. Like he agreed for this webinar with a simple text, and we're always grateful for you, sir, to guide us in every single thing and helping us, especially the IVC students. And yeah, just I would not take much time, and also I would like to thank you the all the IVSA India members as well as non-members who joined this webinar. Thank you so much for coming, and I hope that this webinar will provide something or other to your knowledge. And yeah, thank you so much for joining.
Thank you, Mishwa, and thank you, Ajay. Can you guys please tell me if I'm audible and if you can see the slides?
Yes, sir.
So, should I start?
Yes, sir, we can start.
Okay. Good evening, everybody. I'm Dr. Sumanth Bedre from WVS India. Today, I'm going to present on cardiopulmonary resuscitation in dogs and cats. This is going to be a long webinar, so buckle your seat belts. Hold on. Sorry. At first, we'll discuss about the recovery guidelines for cardiopulmonary resuscitation in adult dogs and cats. And then later we'll discuss about the newborn resuscitation guidelines. So recover is an acronym. It stands for Reassessment Campaign on Veterinary Resuscitation. So in 2010, a group of veterinary emergency critical care specialists, they spearheaded recover initiative. In 2012, they published the first evidence-based veterinary CPR guidelines. They have made some changes in their treatment recommendations over the years, and they came up with the second edition in 2024. So the 2024 CPR guidelines is what we are following as of now. So in this segment, I'll talk about how to assess cardiopulmonary arrest in small animals and the three components of CPR, that is basic life support, advanced life support, and post cardiac arrest care. We'll also talk about preparedness, communication, and team dynamics. So what is cardiopulmonary arrest? So in simple words, it is when your animal stops breathing and the animal's heart stops beating. In humans, primary cardiac arrest is more common. That is, heart stops pumping first, and because of lack of blood flow to the brain, respiration stops. But in dogs and cats, primary respiratory arrest is more common. Here, the animal stops breathing first, and then the heart stops because of lack of oxygen. So the animals undergoing cardiopulmonary arrest will show these clinical signs. They'll be unresponsive, apnea or lack of breathing, lack of pulse, lack of heartbeat upon auscultation. The eyeballs or the pupil will be fixed and dilated. Pupillary light reflex will be absent. Mucous membrane and tongue will be cyanotic or bluish. And in later stages, hypothermia is also seen. So, within the first 4 minutes of cardiopulmonary arrest, the ischemic damage begins to occur due to hypoxia. And then within 10 minutes, the damage becomes irreversible. Therefore, it is very, very important to start CPR as soon as you assess an animal with cardiopulmonary arrest. This is the algorithm for assessment of cardiopulmonary arrest in your patients. If you come across a patient that is unresponsive, immediately call for help. Then shake or stimulate the patient and look for a response. If the animal is not responsive, then check the animal for breathing. This is the most sensitive tool to diagnose cardiopulmonary arrest. If your patient is not responding and if your patient is not breathing, then open the mouth of the patient, make sure the airway is clear and immediately start CPR. Don't waste much time in checking the other signs of cardiopulmonary arrest such as pulse and stuff. Sometimes the animals may show agonal breathing. So here every minute is very important. The delay in CPR leads to reduced survival. So you need to assess your patient quickly, assess for response and assess for breathing. If there is no response, there is no breathing, immediately start CPR. So what is CPR? CPR stands for Cardiopulmonary Resuscitation. This is the only practical method that will revive a patient in cardiopulmonary arrest and achieve the return of spontaneous circulation. So the survival to discharge rates of dog undergoing cardiopulmonary arrest is only 5 to 7%, and that of cats is 1 to 19%. If cardiopulmonary arrest is because of perianesthetic drug reaction, then you have a better chance. The survival to discharge rates can be as high as 50%. Coming to components of CPR, there are three components. The first one is basic life support, BLS. The second one is advanced life support, that is ALS. And the third component of CPR is post cardiac arrest care, that is PCA care. Let us start with the basic life support. Basic life support, it is a 2-minute uninterrupted cycle. Basic life support has two components. One is chest compression to generate the blood flow, and the second one is intermittent positive pressure ventilation to re-establish ventilation and oxygenation. So let's go to the definition of basic life support. It is a set of techniques targeted at the critical function of cardiovascular and respiratory systems in patient in cardiopulmonary arrest to maintain oxygen delivery to vital organs. If only one person is available, then you perform 30 chest compressions and a brief pause to give 2 breaths. This brief pause should be less than 3 to 5 seconds. So this is called as compression ventilation ratio. If there is only one person present, so you do 30 chest compressions and then followed by 2 breaths. Again, repeat 30 compressions and 2 breaths. So this is called as compression ventilation ratio. This is 30 is to 2. Sorry, if there are more people, like in a clinical setting, then one person will do the chest compression, the other person will intubate the patient and cuff the endotracheal tube and perform intermittent positive pressure ventilation. Here, the person who is performing chest compression will aim for 100 to 120 compressions per minute, and the person who is ventilating the patient will aim for 10 breaths every minute, that is 1 breath every 6 seconds. So if you're alone, you need to discontinue compression and give 2 breaths. But if there are more than one person, then one person can focus on chest compression, the other person can focus on ventilation. Let's talk about the chest compression first, and then we'll talk about the ventilation. So let us talk about the compressor positioning first. So the compressor will be standing behind the dog's spine. So we use two-hand techniques. So one hand is put on top of the other hand, interlaced. Elbows should be locked. Shoulders should be directly over your hands. If needed, stand on a stool to deliver compression. If there is no stool available, you can also kneel on the table. Strong core abdominal muscles are used to deliver compressions. So make sure you allow the chest to recoil before you go for the next compression. And we aim at giving 100 to 120 compressions per minute. So these are the images that show you proper and improper compressor positioning. Okay. And then coming to the patient positioning, most of the dogs and all cats will be on lateral recumbency when you are delivering chest compressions. Only the wide-chested dogs, such as bulldog, boxers, can be on dorsal recumbency. For a round-chested dog, the optimal compression point is over the widest portion of the chest. For round-chested dogs, we make use of thoracic pump theory of chest compression that I'll explain you in some time. Then for a wide-chested dog, here the dog will be in dorsal recumbency and the compression point is directly over the mid-sternum. And if you have a keel-chested dog such as hounds, then the optimal compression point is the heel of your hand should be directly over the heart. If you have a small dog which is less than 7 kgs or cat, again the optimal compression point is directly over the heart. So how to find the heart? It is 1/3 the distance from sternum to the spine, as you can see in the image. Okay. For keel-chested dogs, wide-chested dogs, small dogs and cats, we make use of cardiac pump mechanism of chest compression. I'll explain this in a minute. So when we are delivering chest compression for small dogs and cats, we don't use two-hand approach. We use one of these approaches, that is one-hand approach or circumferential approach or one-arm approach. Again, the number of compression is 100 to 120 compression per minute, irrespective of the size and age of the patient. Coming to optimal compression depth, whenever your patient is in lateral recumbency, that is in most cases, the compression depth should be targeted at one third to half the width of the chest. If your animal is in sternal recumbency or dorsal recumbency rather, in patients like English bulldog, then the compression depth should be targeted at one fourth the depth of the chest. So when we perform chest compression in keel-chested dogs, wide-chested dogs, or small dogs or cats, so we perform chest compression directly over the heart. So we use cardiac pump mechanisms. So when we compress when we do chest compression, we compress the ventricle. The pressure inside the ventricle increases. So the aortic and pulmonary valves open, allowing the emptying of both the ventricles. When the recoiling happens, the pressure inside the ventricle decreases, because of which mitral and tricuspid valve opens, which allows the ventricular filling. This is what happens when we do chest compression in these type of configurations. And then in round chested dog, we can't use cardiac pump theory because the chest is very big. So we make, for example, round chested dogs include Saint Bernards, Great Danes. So we make use of thoracic pump mechanism. So whenever we deliver compression, so the intrathoracic pressure increases, the lungs are compressed, so the blood is pushed into left ventricles and aorta. And during recoil, the intrathoracic pressure decreases, the lung expands, and movement of blood from vena cava to right ventricle to lungs through pulmonary artery happens. So basically, blood flow through left side of the heart is achieved during compression, and blood flow through right side of the heart is achieved during recoil. So here, heart acts as a passive conduit. So the basic life support, it is a 2-minute uninterrupted cycle. As you can see, it takes at least 1 minute to achieve the aortic blood pressure to reach a steady state that provides perfusion to heart and brain. If you don't do a 2-minute uninterrupted cycle, and if there are a lot of interruption, you will not be able to achieve the optimal blood pressure that will cause perfusion to heart and brain. So it is very, very important to do a 2-minute uninterrupted compression. Between two cycles, you will take a short break of less than 10 seconds. This is called a pause and check break. We'll explain the importance of this in the coming slides. So remember, the basic life support with 100 to 120 chest compressions per minute, it is a 2-minute uninterrupted cycle. And between cycles, you only have less than 10-second break. So the second component of basic life support is intermittent positive pressure ventilation. The most preferred method of ventilating a patient, or the best method of ventilating a patient, is intubating your patient with the endotracheal tube. Please cuff the tube and then deliver one breath every 6 seconds or 10 breaths per minute with a short inspiratory time of 1 second and a peak inspiratory pressure of 30 to 40 centimeter of water. If there is no ET tube available, then you have other two options. One is with a tight fitting face mask and delivering breaths through ambu bag. The other option would be mouth to nose or mouth to snout breaths. So in these situations, you do 30 compressions and you give a short break of 3 to 5 seconds to deliver 2 breaths, and again get back to doing compressions. If you don't have a cuffed ET tube in place, you cannot do compressions and ventilation simultaneously. So in these cases, you need to do compression, a short break of 3 to 5 seconds, deliver 2 breaths, and again get back doing 30 compressions. That is the compression ventilation ratio of 30:2. But if you have a patient with an ET tube, then one person can deliver 100 to 120 compressions per minute. The other person can deliver 10 breaths per minute. This can happen simultaneously. Okay, so these are the 3 methods with which we ventilate our patients. The endotracheal intubation is the preferred one. So this is about basic life support. Then we move on to the advanced life support. In advanced life support, this also here the basic life support continues. Apart from that, we also include monitoring tools such as ECG, capnography. We also do drug therapies and adjunct therapies in advanced life support. If the cardiopulmonary arrest is because of a peri-anesthetic drug reaction, you need to give an appropriate reversal to the patient. If you have administered a strong opioid, then you reverse it with naloxone. If you have given an alpha 2 drug and that has resulted in cardiopulmonary arrest, then please reverse it with atipamezole. And flumazenil is an reversal agent for benzodiazepines. Coming to the monitoring tools, the first one is capnograph. Capnograph measures the concentration of CO2 in the expired air, that is EtCO2. It tells us three things. One is if your ET tube is in the proper place or not. If your endotracheal tube is in the trachea, you will get the rectangle shaped waveforms that you see in the image. If you're not put an ET tube properly and if your endotracheal tube is in the esophagus, then you will not get the rectangular waveforms. Capnograph tells us the quality of chest compressions. Capnography reading should be always more than 18 mm of Hg. That indicates that you're doing a proper chest compression. And it also tells us about return of spontaneous circulation. So if there is a sudden increase of more than 10 mm Hg, or the overall EtCO2 value goes in more than 35 mm Hg, then this strongly indicates return of spontaneous circulation. So the second monitoring tool we use is electrocardiograph, that is ECG. So ECG rhythm analysis should be done during the period of pause and check. That is the 5 to 10-second break between two basic life support cycles. Unlike capnography, which can be done during chest compression, we cannot do ECG during chest compression because ECG is susceptible to motion artifacts. So it is done between basic life support cycles. So ECG rhythm analysis plays a key role. It tells us what treatment we'll give to the patient. And this is the ECG algorithm for CPR. So when you're doing pause and check and you take ECG between your basic life support cycles and you end up with a non-shockable rhythm, such as asystole or pulseless electrical activity. So these two rhythms, you don't need to defibrillate or shock the patients. So that is why they are called non-shockable rhythms. Asystole appears as a flat line on ECG, whereas pulseless electrical activity appears as a normal sinus rhythm with narrow QRS complex. And here the rate of complex formation is less than 200 per minute. In most cases, it will be around 50 complexes per minute. Sometimes these complexes may be wide and bizarre. So previously, pulseless electrical activity was also called as electromechanical dissociation. So if you have a patient which has undergone cardiopulmonary arrest and you diagnose a non-shockable rhythm, so what is the treatment? So treatment includes one standard dose of epinephrine. Outside US, it is called as adrenaline. That is 0.01 mg per kg. Every other alternative cycle of basic life support or every 3 to 5 minutes. And if your team thinks high vagal tone is responsible for cardiopulmonary arrest, then you give one shot of atropine, that 0.04 mg per kg, IV or IVO. It has to be given only once and not repeated. If your overall CPR time has exceeded more than 15 minutes, then you need to give bicarbonate therapy for metabolic acidosis. So initially in the 2012 algorithm, they also included high dose of epinephrine, that is 0.1 mg per kg. But in 2024 CPR guidelines, they have removed the high dose of epinephrine. So we only have one standard dose, that is the low dose, that is 0.01 mg per kg of epinephrine. You have to give it every other alternative cycle of BLS or every 3 to 5 minutes. You can also use vasopressin at 0.8 units per kg IV or IVO in place of epinephrine. So high dose of epinephrine is no longer recommended in the 2024 CPR guidelines. And if atropine is used, it has to be used early and only once. So this is all for non-shockable rhythm. If you end up diagnosing a patient with shockable rhythm, that includes ventricular fibrillation and pulseless ventricular tachycardia, the treatment is shocking your patient, that is defibrillating your patient. So ventricular fibrillation appears as a wavy, chaotic line on ECG with lack of consistent repeating waveforms, whereas pulseless ventricular tachycardia has waveforms or complexes more than 200 per minute. It is recognized by repeated wide QRS complexes. So the treatment for shockable rhythms is such as VTAC and VFib. It is defibrillation. So you can either use a manual defibrillator or an AED, that is automated electric defibrillator. So the goal of defibrillation is to terminate the uncoordinated and rapid contraction of these ventricles and to restore a coordinated uh, perfusing rhythm. So you can hold the hand paddles on either side of the thorax and discharge the defibrillator. So the dose of external defibrillator is somewhere around 2 to joules per kg, 2 to 4 joules per kg. So after defibrillation, we resume 2-minute uninterrupted basic life support cycle, that is chest compressions. And during pause and check, if the shockable rhythm persists, then we double the dose of defibrillator and shock the patient again. And you have to defibrillate every cycle of BLS. And even after 2 or more shock, if the shockable rhythm persists, it is called as refractory shockable rhythm. So in these cases, we give additional drug therapy, such as one standard dose of epinephrine at 0.01 mg per kg every alternative cycle of BLS, or every 3 to 5 minutes. We also give a beta blocker at esmolol at 0.5 mg per kg IV or IVO, followed by a CRI of 50 microgram per kg per minute. And we use antiarrhythmic drugs such as lidocaine at 2 mg per kg in dog, and amiodarone at 5 mg per kg in cat, slow IV. So this is a drug dosage chart we use for CPR. So this is a CPR algorithm. We start with patient assessment and basic life support with chest compression and intermittent positive pressure ventilation. And in advanced life support, we get an IV access, we give reversals, we take ETCO2, that is capnography, to know whether we're giving proper chest compressions or not. And during pause and check, we do the rhythm diagnosis with ECG. If you find shockable rhythms such as ventricular fibrillation or pulseless ventricular tachycardia, then we follow the left side of the chart. We shock the patient, we use defibrillator. If the shock persists, then we use additional therapies such as vasopressors, antiarrhythmic drugs, and esmolol. If your rhythm diagnosis gives you a non-shockable rhythm such as asystole and pulseless electrical activity, then we continue with basic life support, and as a part of advanced life support, we give vasopressin or epinephrine every other cycle of the basic life support, and atropine at once. In either of the cases, if the CPR has gone more than 15 minutes, we give sodium bicarbonate therapy. So when to stop doing CPR? So the presence of femoral pulse during pause and check, and if there is a sudden increase in EtCO2 by more than 10 mmHg, or total EtCO2 reaches more than 35 mmHg, it is a clear indication of return of spontaneous circulation. Along with this, the animal will also show the signs of consciousness. So the animal will show voluntary movements. The animal may start chewing on the ET tube. There will be return of palpebral or corneal reflexes. So that's when we stop CPR. So there's a concept called open chest CPR. Open chest CPR is recommended for dogs and cats with pleural and pericardial diseases such as pleural effusion, pneumothorax. This is also indicated for animals undergoing thoracic and abdominal surgeries. Here you can do a direct cardiac massage. Open chest CPR is also preferred over closed chest CPR in a giant round chested dog such as Saint Bernard. So give me a moment. And that's all about advanced life support. Then the last component of CPR is post cardiac arrest care. Post cardiac arrest care is the final link in the chain of survival. In veterinary medicine, 79% of dogs and cats with return of spontaneous circulation are either euthanized or die before hospital discharge. So by optimizing this post-cardiac arrest care, we can improve the patient outcomes. So the post-cardiac care has three components, that is respiratory optimization, hemodynamic optimization, and neuroprotection. I'll quickly go through these components. Once there is return of spontaneous circulation in your patient after CPR, so first thing is respiratory optimization. You need to check your patient is breathing on its own or not. If there is spontaneous breathing, well and good. If not, you need to ventilate your patients. If the animal is breathing, then you need to use capnography to see if the animal is hyperventilating or hypoventilating, and then address accordingly. After ventilation, the next thing you need to check is oxygenation. We use blood gas or pulse oximeter to check oxygenation of the patients. If the SpO2 reading is less than 94%, and if partial pressure of oxygen is less than 80 mmHg, so that is a hypoxemic state, then only we consider giving additional oxygen. So once the animal is recovered from CPR, please don't blindly give oxygen just like that, because you will do more harm. There's a concept called ischemia reperfusion injury syndrome. So only if oxygen support is indicated, that is SpO2 reading of less than 94% and partial pressure of oxygen is less than 80 mmHg, then only consider giving oxygen support. So the second component of post-cardiac arrest care is hemodynamic optimization. Once the respiratory optimization is done, then you check the blood pressure of your patient with the Doppler or oscillometric blood pressure monitor. If the patient is hypotensive, that is, if the mean arterial pressure is less than 80 mmHg and systolic arterial pressure is less than 100 mmHg, figure out why there is, hypotension. Is it because of hypovolemia? If so, you give IV fluids. If hypotension is because of vasodilation, then we use vasopressors such as dopamine or norepinephrine. If hypotension is because of decreased cardiac contractility, then we use a positive inotrope such as dobutamine. If the patient becomes hypertensive, then we discontinue giving vasopressors and we investigate why there is hypertension. Is it because of pain, anxiety, and we treat accordingly. The third component of post-cardiac arrest care is neuroprotection. If an animal shows signs of increased intracranial pressure, such as if the animal is comatose, decreased mentation, if the animal has a persistent apnea or hypoventilation, then we give either mannitol or hypertonic saline to reduce the intracranial pressure. Also, if the animal experiences seizure during post-cardiac arrest care, then we give benzodiazepines or levetiracetam. This is post-cardiac arrest care in brief. There are three components that we need to optimize the respiration first, then there is hemodynamic optimization, followed by neuroprotection. Coming to prevention and preparedness, a thorough pre-anesthetic evaluation and close monitoring of patient under anesthesia will help you to reduce the incidences of cardiac pulmonary arrest. So proper anesthesia monitoring is very, very important. Make sure you have an emergency crash kit in your place, clinic or OT. It should contain reversal vasopressors, positive inotropes, etc. All the drugs needed for reviving your patients. And paste the drug dosage chart and algorithm charts on the clinic and OT wall. Perform refresher training mock drills very often, every 3 to 6 months, so that your staff are familiar and everybody is on the same page. Just give me a moment. Coming to communication and team dynamics, during cardiopulmonary arrest, usually the senior or the most experienced person will take up the leadership. He or she will assign the roles for team members, such as who will be the compressor, who will be the ventilator, who will be the drug handler, and who will record the events. Closed loop communication is very, very important. The messages should be brief, clear, and timely. Situation awareness and cross monitoring is also extremely important. This is all followed by a debriefing session. So the take-home messages include you download and read the record CPR guidelines, and please take printouts and paste CPR algorithm and drug dosage charts in your clinic and OT. Please take consent and obtain resuscitation code from the pet parents before admitting the patients. for hospitalization or surgery. So there is Recover CPR app. You can download it from Google Play Store or Apple Store. So my reference was 2024 Recover Guidelines. So this is an open access article. Anybody can download and read it. And if you really want to know more about CPR and if you're interested in emergency critical care, you can go to Recovery Initiative website. They offer courses on CPR. They offer courses on basic life support, advanced life support, post cardiac arrest care, and all. So if somebody is interested, you can look into that. So this is in brief about CPR guidelines in adult dogs and cats. So now let's briefly talk about the recover guidelines for newborn resuscitation. This came out last year in 2025. So the goal of newborn resuscitation is to support the animals at birth through their transition from intrauterine to extrauterine physiology. So within minutes of birth, the newborn must aerate its previously fluid-filled lung. So there's a clear transition in how blood circulates in heart and lungs. So this is called as cardiopulmonary transition. During intrauterine life, the fetus gets oxygenated blood from the mother from umbilical vein. When this oxygenated blood reaches the right side of the heart, because of foramen ovale, 50% of this blood goes from right atrium to the left atrium. And in the remaining 50% that reaches the right ventricle, because of ductus arteriosus, most of it goes to the descending aorta. So therefore, in fetal circulation, the blood supply to the lungs is very, very limited as it is not the site of gas exchange. But when the animal is born, it enters the extrauterine physiology. This transition takes place during birth. It may take few minutes of birth during birth. When the animal aerates lungs, so it completes the cardiopulmonary transition. So after aeration of lungs, there will be closure of foramen ovale, closure of ductus arteriosus. So now the right side of the heart pumps blood to the lungs for oxygenation, and the left side of the heart receives this oxygenated blood from the lungs, and it is pumped to the other organ systems. So I want you to know the difference between these terminologies. So whenever a puppy or kitten is born, within the first few hours, it is called as newborn. And till it reaches a couple of weeks, till we initiate weaning, it is called as a neonate. From its weaning period to till it attains sexual maturity, that is around 5 to 6 months of age, it is called as a pediatric. So there's a high mortality among C-section delivered litter. So the recover team came up with new guidelines for the newborns because their physiology is slightly different from the adults. As I told earlier, for these newborns, there is a transition from intrauterine to extrauterine physiology taking place. So we have to follow a different guidelines for this. First, we need to decide which newborn needs resuscitation. If the puppies and kittens are born via normal parturition or eutokia, and if the mother is able to provide care, and if the newborn animals are vigorous, they're breathing, they're vocalizing, they don't need resuscitation. You just need to keep them warm with the mother and do routine postpartum care. So this routine postpartum care includes UPGAR scores. It is taken at 5 minutes, 30 minutes, and 60 minutes after birth to identify the risk of deterioration. So UPGAR score is it is a scale used to evaluate the newborn viability. These have several parameters such as mucous membrane, heart rate, reflex irritability, motility, and respiratory efforts. And the scores are given from 0 to 2. If a newborn has an UPGAR score of more than 7 or 8 out of 10, then that means the animal is doing well. The lower score indicates more severe depression. If the UPGAR scores are less than 6 or 7, then you need to keep an eye on this neonates, newborns, because they may end up with cardiopulmonary arrest. So this scale will give you some idea about evaluating their viability. The routine postpartum management also includes taking weights of these puppies and kittens twice a day, and umbilical management that includes ligating the umbilical cord 1 centimeter from the body and then disinfecting it with 2% tincture iodine. If the puppy or kitten is not born via normal parturition, if they are born via C-section, then you need to do this within the first minute. You need to rub them and dry them. So this will stimulate breathing. You need to clear the airway. So just with a towel for the vigorous ones, and you can use the suctioning tubes such as nasal or oropharyngeal suctioning for the non-vigorous puppies and kittens. So we aim at getting the temperature to 95 to 97 degree Fahrenheit, so that you can set the incubator temperature at somewhere around 29 to 32 degrees Celsius. So within the first minute of the birth, you need to assess the heart rate and respiration of the animals, the newborns. If the heart rate is more than 120, so how do you assess heart rate in puppies and kittens, the newborns? It is via with your stethoscope, or you can use a Doppler ultrasound probe on the thorax of these newborns. If the heart rate is more than 120 per minute, if the respiration is normal, that is more than 15 to 20 per minute, generally the newborn puppies will have a respiration of more than 40 per minute, and the kittens will have a respiration more than 70 per minute. So if the respiration is just more than 15 per minute, and if the heart rate is more than 120 per minute, then you just have to do the routine postpartum management. If the heart rate is more than 120, but the animal is showing some respiratory distress or cyanosis or less respiratory rate, then we ensure the airway is patent and we can give oxygen supplementation. In worst case scenarios, we can give doxapram. So if the mother has received any of the drugs such as opiates, then we use a reversal naloxone. If the mother had received alpha agonist, then we use atipamezole. If the mother had received a benzodiazepine and you think the puppy is not able to breathe because of the drug, then we use the reversal flumazenil. In these cases, we use appropriate reversal. We give oxygen supplementation, and we ensure patent airway. If the animal recovers, if the respiration rate goes above 15 per minute, then we just need to do the temperature management and take care of the puppies. So this is the drug dosage chart we use for newborn resuscitation. If the animal becomes apneic or gasping for breath, or if the heart rate drops less than 120 per minute, then you need to do positive pressure ventilation with a tight fitting face mask. You need to give 20 to 30 breaths per minute with a peak inspiratory pressure of 20 to 25 centimeter of water with an atmosphere room air only. You can use cricoid pressure to compress the esophagus to prevent gastric distension. And see, administration of positive pressure ventilation is very important step to support the lung aeration in newborn that are non-vigorous and apneic or gasping. Generally, atropine is not recommended in newborn because it causes severe ischemia, so we don't use it. So this has to be done within the very first minute. That is the key. So after first minute, if the animal is still bradycardic, if the heart rate is still less than 120, then you can consider doing positive pressure ventilation with a tight fitting face mask, but with oxygen this time for another 1 to 2 minutes. Or if you're able to, intubate the patient, then you can do it with a ET tube and ventilate the patient with 100% oxygen, and again reassess the heart rate. If the heart rate is not improving and if it is falling below 50 per minute, or if the puppy or kitten doesn't have a heartbeat, then you need to start doing CPR. So you can do CPR in lateral recumbency or dorsal recumbency. So when you're doing lateral compression, we aim at uh, you know we target at compressing the chest 1/3 to half. When you are doing compressing the chest in dorsal recumbency, then our we target compressing the chest 1/3 the chest diameter. So here the compression to ventilation ratio is 4:1. You compress, give 4 compressions and give a breath. Give 4 compressions, give a breath, and then assess this patient every 30 seconds once. But if you're able to put a cuffed ET tube for a big breed of dogs, for example, if you have a Rottweiler or Saint Bernard puppy, so you can intubate them with 2 size internal diameter ET tube. And then if you're able to do that, then you can simultaneously do compressions and ventilations. In that case, you have to give 120 to 150 compressions per minute and 20 to 30 breaths per minute. Ventilate them. And vascular access is also very important in puppies and kittens, but we know it's very difficult to get vascular access. So you can use umbilical vein or you can use intraosseous route. So we give epinephrine at 0.02 mg per kg IV or IVO every 3 to 5 minutes of ongoing CPR. As you can see, this is actually the double the dose that we use in adult CPR. If you are unable to get a vascular access, then you use 5 times the dose of epinephrine and give it intratracheal route or intranasal route. We need to continue doing CPR and giving epinephrine once every 3 to 5 minutes for at least 20 minutes before discontinuing it. Apart from doing CPR, the urgent interventions are also very important. The blood glucose management is very important. So you can use the paw pad of the puppy or kitten to get a blood sample for glucose estimation. If the animal is hypoglycemic, supplement them with oxygen. Temperature management is also very important. And if your CPR efforts have gone more than 10 minutes, then you need to give sodium bicarbonate therapy for metabolic acidosis. Uh, this is the algorithm for CPR in newborn dogs and cats. This was published last year. So this is again a new open access article. Anybody can download and read it. So that's in brief about CPR in adult and neonates. Yep. So let me know if you guys have any questions. So let's see.
Sir, I had a question.
Yeah.
So, sir, there's always a risk of breaking ribs while we are giving CPR. So,
Yes.
that may lead to complications like pneumothorax or hemothorax. So,
True.
if we know that the ribs are getting broken, then should we
Yeah.
continue with the process or should we change our method? What should we do?
Um, First of all, the chance of you breaking rib is extremely low. So we do something called as risk benefit assessment. We have to continue doing CPR. The thing is, if you think rib is broken, you can opt for open chest CPR also, and later you can always correct, pneumothorax or hemothorax. It's not a big deal.
Okay, sir. Thank you.
Yeah. Okay. Where to find the questions? Can somebody help me with this? So,
So, there's one in the chat box.
yeah.
Does intracardiac injections help?
Uh, so, so what we have seen in colleges and in many practices is people give epinephrine intracardiac route, but there is no mention of it in the recover guidelines. If you are unable to give it IV or IVO, then the next best option is giving it intratracheal administration, but you need to increase your dose 5 to 10 times the dose. So no, the intracardiac injection doesn't help. Actually, it worsens. So that's why it is not recommended in the recent guidelines. So somebody is asking if a patient came with a severe anemia and during treatment, if the patient collapsed suddenly, should we give CPR at time? At that time, definitely you need to give CPR. You revive the patient. Once the patient is revived, you do the post cardiac care. There, when you're doing hemodynamic uh, stabilization, if the animal is having anemia, you need to consider doing a blood transfusion in that case. But the first thing is CPR. First, you need to revive a patient, and then only you can consider giving whole blood or concentrated RBCs. Any other questions?
Sir,
Yeah.
Sir, are there any situation where we are not allowed to do CPR even after the animal is going into cardiopulmonary arrest?
Uh, Hold on just a second. Okay. So there are very few cases where we choose not to do CPR. One is, an animal is suffering from a chronic CKD, chronic kidney disease, and the animal is around 13 years or 14 years of age. Or if an animal has metastatic neoplasia, malignancy, there is no point reviving if you are unable to give a good welfare. So there is no point doing CPR. In very rare cases like that, we don't go for CPR. Like, chronic uh, diseases or malignancy, those cases, again, we need to have a discussion with the owner, and there are very rare cases we don't go for CPR. Otherwise, every other case, as vets, we try to save our patients.
Okay, sir. Thank you.
Thank you. I'll quickly share the last slide. So if anybody has any more questions, you can, yeah, I think you guys can see my mail ID. If you have any questions, feel free to mail me, and I can get back to you with suitable reference material within the next couple of days.
Sir,
Yeah,
there's one person who has
sure,
raised their hand. Sanjay. You
sure.
can unmute yourself.
Dr. Sanjay, are you there?
Maybe by mistake.
So if there are no questions, then I think we should conclude
Uh,
this.
yes, sir. Sir, I'll
Yeah.
be speaking on behalf of everyone here when I'm saying that it was a wonderful webinar and we genuinely learned a lot about CPR, because CPR is something that's like talked about a lot, but if given like correct technique, we can actually like save our patient.
True.
So thank you so much for this webinar and thank you so much for taking some time out for us students. It was truly wonderful.
I would like to thank everybody who has attended this webinar. They have taken time from their schedule to attend this webinar, and I want to thank Ajay and Mishwa in particular for making everything possible. I truly appreciate you guys. Thank you so much.
Thank you so much, sir.
Thank you. If any further doubts, they can mail me anytime. Thank you.